Honorable Vice Chancellor, Tamil Nadu Veterinary and Animal Sciences University, Professor Dr. C. Balachandran, internationally acclaimed speaker of today's webinar, respected Dr. Carla Carleton, Professor Emeritus, Large Animal Clinical Sciences, College of Veterinary Medicine, Michigan State University, USA, the Organizing Secretary, Dr. G. Vijay Kumar, the Co-Organizing Secretaries, Dr. Krishna Kumar and Dr. Gauri, Deans of Constituent Veterinary Colleges, Heads of the Department, faculty members, participants from India and other countries. Greetings and a very warm good evening to one and all. I'm here to give a brief note about the webinar series which is being organized by TANUVAS. Under the guidance and unstinted support of the Honorable Vice Chancellor, the Directorate of Clinics TANUVAS has so far organized 2 webinars during 2019 and 2 webinars this year exclusively for the benefit of veterinary undergraduate students of all 4 constituent colleges of TANUVAS. Subsequently, the Directorate of Clinics has organized for the first time TANUVAS Global Veterinary Clinical Sciences Webinar 2020 in the month of August on 21st on anemia and blood transfusion medicine in chronic kidney diseases in canines by Dr. Carolina from Poland. Later in the month of September, we had TANUVAS Global Veterinary Imaging Sciences Webinar Series 2020, organized during 16th and 17th September, in which we had 2 international speakers, Dr. Natasha Moto from West Indies and Dr. Lara Martinelli from Italy. And last month, we had a special webinar, World Anesthesia Day 2020, commemorative webinar on critical care anesthesia in trauma, critical care, and emergency by Dr. Kirk Munoz, Michigan State University, USA, on 16/10/2020. In continuation of the above dedicated efforts of this Directorate of TANUVAS, the Veterinary University Peripheral Hospital, Madhavara Mill Colony, is now organizing this Global Veterinary Large Animal Sciences Webinar Series 2020 from 6th of November till 8th of November. We have 4 speakers, and today we have the eminent speaker, Dr. Carla Carleton, and on 7th we have 2 speakers, and on 8th we have 1 international speaker. I am confident that this webinar series will certainly be beneficial to all the participants. Thank you.
May I request on behalf of the organizing committee, Dr. C. Balachandran, Honorable Vice Chancellor, for the presidential address.
Good evening from India and greetings from Tamil Nadu Veterinary and Animal Sciences University.
Request on behalf of the organizing committee,
as a part of the program,
Dr. C. Balachandran, Honorable Vice Chancellor, for the presidential address.
Directorate of Clinics on continuing veterinary education. So we have been organizing conferences.
Good evening from India and greetings from Tamil Nadu.
We are also organizing
Animal Sciences
webinars, which we have the esteemed colleague, Dr. Balasubramanian, Director of Clinics, and the organizers, Dr. G. Vijay Kumar, Dr. K. Krishna Kumar, Dr. Gauri, and the distinguished speaker, Dr. Carla Carleton, and all other dignitaries and dear participants. Once again, welcome you to this edition of webinar. So this is event 3rd in the series of webinars organized by the Directorate of Clinics. It is exclusively for large animals, and it is focusing on the ultrasonography. So this has become an essential imaging modality in the field of veterinary science and is increasing in popularity year by year, and sonography is a fast and a non-invasive procedure which can greatly increase a veterinarian's diagnostic and therapeutic capabilities. So this sonography is playing a prominent role in the history of veterinary medicine, and as I am given that the first written document dealing the use of ultrasound waves dates back to 1794, wherein an Italian physicist, Lazzaro, used this methodology for identifying the navigation capability of flying bats in the dark, and rightly deduced that bats employed sound rather than light to orient themselves. Then later, Jackson Pierre Curie discovered the piezoelectric crystals which formed the heart of ultrasound machine. Jan Donald introduced the ultrasound in diagnostic and medicine in 1956 when he used A mode to measure the parietal diameter of the fetal head, and later B mode and Doppler ultrasound came into existence. Since the early 1980s, the use of ultrasound has revolutionized the understanding of equine reproductive physiology and stud management. The ultrasound allows to diagnose problems and monitor reproductive activity with considerable accuracy. Additionally, the non-invasive nature of the technique reduces the risk of harming the mare or her fetus and allows sequential monitoring. Today, ultrasound is regularly used to monitor ovarian activity and to diagnose and monitor pregnancy and reproductive abnormalities. So the other side is on the colic, is one of the important abdominal emergency conditions in horses, and early diagnosis is important to avoid mortality and also for institution of therapeutic measures at the early stage. So ultrasound imaging is playing a major and is a good tool for the veterinarians. A quick and accurate assessment of the horse with acute abdominal pain is very important, and ultrasonography can really satisfy this goal. So abdominal ultrasound is safer than abdominal palpation per rectum and more accurate in detecting small intestinal strangulation and obstructions. So consequently, more diagnostic information can be obtained earlier in the disease course, resulting in earlier therapeutic intervention. So the color Doppler ultrasound scanners with specifications on par with other developed countries are available in all the constituent colleges of TANUVAS. We have 4 such colleges, and Madras Veterinary College is the oldest institute, is around 117 years old. Manipulation of adipose tissue lipolysis is an important aspect in the management of periparturient cows, and adipose tissue lipolysis not only involves the release of fatty acids, neutral lipids, and glycerol, but also induces a remodeling process of the organ. So that is characterized by inflammatory response with immune cell migration, proliferation of the cellular components of the stromal vascular fraction, and changes in extracellular matrix of adipose tissue. So intense research during the past 2 decades has characterized AT remodeling in human diseases that exhibit high AT lipolysis rates such as obesity, metabolic syndrome, and lipodystrophy. So more recently, different aspects of AT remodeling in dairy cows during the transition period and metabolic disease were evaluated, and it is learned that they will be actively discussed during the webinar. Of course, we have got several distinguished speakers. To start with, Dr. Carla Carleton will be dealing on the reproductive ultrasonography in mares and stallions, and followed tomorrow by Dr. G. Andres on modulating adipose tissue functions in periparturient cows, and by Dr. Elizabeth on medical management of colic in horses. And to conclude, Dr. Cleary will be dealing on ultrasonography in horses, last of the speak. So hope these deliberations will be useful in understanding the basics of ultrasonography in reproduction, applications of abdominal ultrasonography, management of colic in horses, and modulation of adipose tissue in periparturient cows. I hope it will be benefiting the undergraduate, postgraduate students, and the practitioners, and acquire important technical and field-oriented skills. I'm happy to note that participants from 12 countries, including India, numbering around 1,370, are there online. Just happy that this event will be very useful to you. I congratulate the organizing team and wish them a good luck for the successful conduct of the webinar, and thank the organizers for giving me this opportunity.
Thank you very much, sir. And then you are given salient points on each of the topics to be covered in this webinar series. Again, thank you, sir. May I request Dr. K. Krishnakumar to introduce the speaker.
Good evening to all and good morning to all. On behalf of Organizing Committee, TANUVAS Global Veterinary Large Animal Sciences Webinar Series 2020, it is a great pleasure for me to introduce our speaker, Dr. Carla Carleton, DVM, MS, Diplomate ACT, Professor Emeritus, Large Animal Clinical Sciences, College of Veterinary Medicine, Michigan State University, USA, who is going to talk to us about the reproductive ultrasonography in mare and stallions. Dr. Carla Carleton is a graduate of Kansas State University, College of Veterinary Medicine. Following her DVM studies, she was in private practice, especially large animal practice in Western Oklahoma. Then pursued her goal of becoming a theriogenologist by completing a comparative species theriogenology residency at Ohio State University. After the residency and having passed her specialty board examination, she accepted a faculty position at Michigan State University. Her focus during her 35 years at College of Veterinary Medicine, Michigan State University, was equine theriogenology, didactic and laboratory education for veterinary medical students, residency training, clinical service on local stat forms, and a referral service for cases at College of Veterinary Medicine, Michigan State University. Since leaving College of Veterinary Medicine, Michigan State University, she has taken up a role as an adjunct professor at Tuskegee University College of Veterinary Medicine in Alabama to teach students remotely during the pandemic. She continues her consultation with thoroughbred farms in India and working equids in Thailand and Cambodia. She appreciates the opportunity to share some of her clinical cases and experience with attendees. Once again, I welcome our eminent speaker, Dr. Carla Carleton. Thank you.
Thank you, Professor Krishnakumar, for a brief introduction of the speaker. Now it's over to Dr. Carla Carleton. We are eagerly waiting for your webinar on reproductive ultrasonography in mares and stallion. Dr. Carla, please.
Well, first off, I want to also welcome everyone who's taken the time out, and hopefully the time that I'm going to spend with you will be well spent. But I really want to thank the conference organizers and the administration of TANUVAS for their really kind invitation to participate in the Global Veterinary Webinar Series. So my topic today is the use of ultrasonography in the examination of the reproductive system of mares and stallions. It's clearly an enormous topic, and so I had to pick and choose some of the topics and subjects that I wanted to cover. So the use of ultrasonography, as already noted, goes way back to bats and other things that are way beyond my purview. But in my experience in the use of ultrasound in examining equids, it has really been in good clinical use for approximately 40 years. When I first began using a very basic ultrasound unit during my residency so long ago, each day was exciting and challenging as we were learning along with everyone else who was first using this in equine therio. Since that time, clearly, the quality and capabilities of the instrumentation have improved dramatically. There are so many books and papers that are written on specific aspects of ultrasonography in great detail. So what I've opted to do today is to begin with a basic primer. As I was told, the experience of attendees is quite wide-ranging. Excuse me. It would be difficult to address advanced techniques in such a short time frame, so I've chosen to address clinical topics that are most likely to be encountered by practitioners who are using ultrasound as a diagnostic tool. I'll begin with the mare and then switch to some likely challenges that can be encountered with the examination of stallions. So I'm building on the assumption that attendees today have knowledge regarding the seasonality of equids. From the years of teaching and consulting with veterinarians in India, it has been really clear to me that the dramatic seasonal effects on mares that I observe and encounter in the States result in a much smaller percentage of mares maintaining any ovarian activity throughout the year. Whereas in India, I often have seen mares exhibiting regular estrus cycles in November and December when the mares in my part of North America are really shut down completely. And so we don't have the winter anestrus that's as deep and as thorough as it is in India, where we see mares that are continuing to cycle really almost some of them year round. So to fully appreciate the impact of seasonal changes on the mare, with each exam, I find it's really important to record findings that transcend just looking at what the ovaries are doing. I've been in practices around the world in actually Northern Africa, and when I first went to Australia back in 1990, where the emphasis was always on ovarian activity. But for me to do a complete exam that lets me know best what's happening with the mare, I have to really not only focus on the ovaries, but also the size and tone of the uterine horns and the degree of relaxation present in the cervix. It is of little use to me only to examine the ovaries, whether it's by transrectal palpation and, of course, the use of ultrasound, without knowing what's happening with the bigger picture, because what's happening on the ovaries affects the uterus, it affects the cervix, and it affects so much of what's going to happen with that individual and our ability to hopefully maximize her reproductive ability. So it does take more time to become proficient to use not only palpation more fully on all parts of the genital tract, but also to add ultrasound to that. But with practice, I think you'll find that it doesn't take too long to conduct that more thorough exam that will help you assess if the mare is normal and if she's making progress that you need for her to do towards breeding and ovulation. So it's important. And I'll make a note in here. I want you to realize that I'm going to limit the ultrasound images that I show today to those that are done with a linear probe. And most of the time with a mare exam, it's going to be a 5 megahertz transducer, whereas on the pelvic exams of stallions, we generally use a 7.5 megahertz. And then if we use scrotal exams, then we go ahead and use the 5 megahertz again. So what I want to do at the start of this is to just go through some of the normal things that I would be looking for, or I would anticipate a normal horse would experience throughout a calendar year. So this is really basic. This will take about 5 minutes, and then we can move on to some of the other clinical conditions. So during the ovulatory period, when a mare is in estrus, progesterone is going to be low, and a dominant follicle will be developing and producing estradiol. The endometrial folds, in response to that estradiol, become edematous, and the cervix, when there is no progesterone present and estradiol is high, the cervix becomes shorter and wider and becomes flatter as it relaxes. It's much more dynamic than is the cervix of a cow that has 3 to 5 cervical rings, and it stays pretty much the same regardless of the stage of a cow cycle, whereas in horses, it's very much a reflection of the bigger picture of what she's experiencing. I record in the ovulatory season follicular development, uterine horn size and tone, as well as the percent of cervical relaxation with each exam I do, not just to track along a dominant follicle in its development. I have read some older papers, and they describe dominant follicles, the one that's heading towards ovulation, increasing at most 2 to 3 millimeters in diameter each day. But for the 30 plus years that I worked on stud farms and still do, the daily growth rate that I find in dominant follicles and have recorded for years has averaged about 5 to 6 millimeters per day. And those are on standardbred horses primarily, but also some warm bloods and Arabians and Morgans and some other lesser breeds. But daily examinations in my world are unnecessary because standardbreds allow artificial insemination. So individuals working with thoroughbreds clearly have to track those mares much more closely. So when I'm doing an exam, say, for example, I found a 30 millimeter follicle present on a Wednesday, I would expect that follicle to be approximately a 40 millimeter follicle by the time I return and examine her next on Friday. Endometrial folds, still in the ovulatory season, can both be palpated and observed with ultrasound. The cervical length, width, and tubularity, though, are assessed only by palpation. The cervix can be seen as one withdraws a transducer from the tract of the mare, but it's really just a sideways linear view. It does not give you the additional detail that you get with transrectal palpation. In normal mares, that edema that is a reflection of estradiol from the follicle begins to lessen and it diminishes in the final hours leading up to ovulation. And most of the farms that I work with use a scale of 1 to 5 for endometrial edema, with 5 being the maximal edema that has been registered. So these are some images of mares that were taken at the time of estrus. So what I wanted to just point out is a few things for those of you that may just be beginning to use ultrasound, or for some of the veterinary students it might be helpful, that in the lower corner here we have a mare, Bridge Mistress, and at that time she had 2 dominant follicles. One was 5.7 centimeter and the other is 4.34. For individuals who work with cattle, they're going to say that's cystic ovarian disease, but this size follicle is absolutely normal in horses. But twinning, as we'll get to later, is an undesirable occurrence in the life of a mare. This is a full ovary up top. You can see the ovulation fossa at the base. But what I wanted you to note is we have this beautiful follicle at one of the poles of the ovary. And it is possible for a follicle to be located anywhere on the surface of the mare's ovary. But because of the tunic that is around her ovary at all times, all of her ovulations must occur and come out through the ovulation fossa. So you may palpate the ovaries, as we routinely do, off of the ovarian surface, but this little ovary down here on the half shell is a really good way to appreciate how different the mare is than the cow. This is the tunic that goes around the mare's ovary, and when we get to large ovary syndrome, it becomes important. We'll refer back to this. But you can see this mare at the time she was put down had a beautiful big dominant follicle. And so we measure it from one side to the other side in centimeters. But even though it protrudes off of the surface of the ovary, as it progresses towards ovulation, it develops this beautiful point that seems to erode through the ovary and make sure that at the time of ovulation that ovum is going to escape and be captured down here in the ovulation fossa and picked up by the fimbria to go to the uterine tube. So that takes care of the ovaries, and then we have a cervix at this point that would be relaxed, and the ultrasound image on the right-hand side shows those glorious endometrial folds and their normal edema that happens in mares when she's in estrus, and this is in response to the estradiol that's being produced by the follicles. So let's continue on. Dominant follicles can be really large, and it's also possible to have multiple follicles present. Again, it's a difference between that and cattle. This is just a dominant follicle on this one, and you can see how big it is. And as they get close to ovulation, they can soften to some degree, but they don't always soften. Some mares will have tense follicles right up to the point that they ovulate without ever having exhibited any softness whatsoever. On the right-hand side, it was a mare called Willow that had not only one very large follicle, but a smaller one at the same time, so taken on the very same day, the same time. But what I wanted you to observe is on this follicle, here's this beautiful point of the follicle on the left-hand side that's already showing that nice little point that's aiming towards the ovulation fossa. So in preparation for ovulation, it's getting closer and closer to the fossa, and it will evacuate out through this very distinct point. Even though this follicle looks just round, if you turn the transducer, you would be able to get that same ovulation point showing on that one too on the right. So it's all a matter of the orientation of the transducer. In addition to that, the cool thing about mares, well, I think it's cool because I love working with mares, you can see this beautiful luteal cell lining within this ovulatory follicle. And the lining of every single follicle has a layer of luteal cells, so that the mare, as she approaches ovulation, is already beginning to build a concentration of progesterone. So within 24 to 48 hours after she ovulates, she's going to be able to have this rapid increase in progesterone that takes her out of heat very quickly. And within 1 to 2 days after ovulation, the luteal cells will be really exuberant in their production of progesterone, and the cervix will be closing because of the effect of progesterone. Uterine tone will be increasing because of the progesterone from the follicles, and all of that is well and good in the mare. But there will be some mares that have this really enormous lining, but please just recognize that that's a normal occurrence in the mare. So uterine tone or responsiveness actually in the mare decreases as she progresses from diestrus to estrus. Following ovulation, as progesterone is being produced, edema should no longer be there. Uterine tone is going to increase, which is in contrast to what happens in cows, and the cervix will close pretty rapidly. So twice I think I've mentioned that edema is present in relationship to estradiol, but after ovulation or just prior to ovulation, that edema begins to diminish. So clinically, if you have a mare has a known time of ovulation and you are checking her right after ovulation or in the next day or two, there should be no residual edema left in those endometrial folds. So a clinically important point is if you see persistent endometrial fold edema after ovulation, you probably need to start considering that that mare is experiencing a low level of endometritis. something that may actually have a negative impact on her ability to conceive and to actually establish that next pregnancy. So food for thought. Okay, let's see. So as we had those images of what the mare's tract is going to look like and feel like and appear on ultrasound in estrus, this is the diestrus series that I think will be helpful. So here we have an ovary that has been cut in half, and you can see where she had this beautiful big ovulatory follicle, and yet here's where it was on the surface of the ovary. But even after ovulation, you can see that beautiful tract that was right down to the ovulation fossa. And here it is soon after ovulation, and you can see that thick layer of luteal cells that were just waiting to kick off and start producing progesterone. An ultrasound of that very same view shows the nice little point that was at the ovulation fossa. Down here is the greater curvature of the ovary, and here we have this luteal cell lining that is rapidly thickening and producing progesterone as that mare moves into diestrus. There are many follicles that will either appear very solid on ultrasound or may retain a fluid core, and they're both normal functioning corpora. Once the ovulation site has matured, the surface of the ovary will no longer be a good indicator to you that there has been an ovulation. You may only be able to find the CL by ultrasound because it won't be apparent on palpation. But the neat thing is here is you can see from the greater curvature of the ovary, here was that beautiful tract just like you saw in ultrasound, just as you saw on that dominant follicle in the prior slide, how they all aim right down towards the ovulation fossa. Ultrasound, though, is that incredibly valuable tool in the horse because twins are undesirable. And you want to know as early as you can in her cycle if she has more than one ovulation, because then she becomes a higher risk mare with the potential for twinning. So in this lower ultrasound image that is a pretty classic, neat image that I took years ago, here is one CL, and you can still see that point was very apparent that went down towards the ovulation fossa, and sitting right next to it was a second ovulation. So on one ovary, we had two ovulations, and those have become two CHs, and now they're two very mature CLs. So this would be a hard twin suspect to miss. But don't forget the mare has two ovaries. She could just as easily have had an ovulation on the right ovary and on the left ovary and have the very same circumstance being a potential problem for you and have twins that could be a very undesirable thing that you need to have on your checklist to take care of as soon as you realize what she has done. Okay, we'll move on into that autumnal transition as we go around the annual calendar year of what the mare does. Follicular activity at the start of autumnal transition continues, but as the hours of daylight start to diminish, pineal gland activity suppresses the hypothalamus, and that results in a decrease of GnRH, and then because GnRH is diminishing, LH begins to decline. And then finally, we don't have the ability of that mare on her own to have an ovulation, regardless of how many follicles are still present on her ovaries. So in the fall, at this time in Michigan, I can still palpate a lot of mares who have numerous follicles on their ovaries, but they're not ovulating because of LH. So FSH hangs around a little bit longer, and then LH kind of, jumps off the bandwagon really fast and leaves all of the follicles behind. So autumnal transition follicles will be numerous. They can become really large. They're slow growing, though. They don't go at the growth rate of a dominant follicle at 5 to 6 millimeters per day. So they grow slower, but they can become really large. The biggest I've found over the years was about 12 centimeters, and that's one whale of a follicle. As fall transition continues, though, FSH production gradually decreases, leading to ovarian activity subsiding even further. And that finally puts us into winter anestrus, at which time there is pretty much severe suppression of GnRH by the melatonin-like substance from the pineal gland. And because there is no GnRH, there's no FSH and LH, meaning there won't be any new follicles developing, there won't be any corpora lutea, and the uterus, in the absence of progesterone, tone just decreases and the uterus becomes flaccid. The cervix, if there's no progesterone out there, it's not going to stay closed, so it too relaxes. And the mare's behavior, since she no longer has progesterone or estradiol, doesn't have a good estrus, doesn't have a good diestrus, and she becomes much more like a gelding when she has really suppressed ovaries. That's just the nature of the beast. And then once we get past the end of December, we start sliding back into the vernal transition mode as day length increases. And in Michigan, that becomes a really big deal because our shortest day of the year at my location is a 9 hours and 2 or 3 minutes. So people sometimes experience what we call SAD, seasonal affective disorder, because of the lack of sunlight. So we get really excited in Michigan when we know vernal transition is around the corner and the next equine breeding season is approaching. Vernal transition begins slowly at first. The ovaries are going from that tiny, small, they can be as small as a peanut, so the dynamics of the mare's ovary are quite extraordinary. We go from this small ovary that begins to be stimulated by light, and that little bit of ovarian activity, that flaccid uterus, and the relaxed cervix in these non-pregnant mares begins to change. Her behavior changes can be very overt, and she will exhibit sustained or irregular estrus-like behavior. And as that light exposure continues, she's going to begin to develop waves of follicles. They'll wax and wane, and they start increasing in both number and size. But their growth rate is, again, not the growth rate of a dominant follicle. It'll be slower growing, but they can, again, just as in autumn follicles, vernal transition follicles can become really large and numerous, sometimes anywhere from 10, 15, 20 follicles of different sizes on each ovary. The final wave of these follicles, though, as she nears the time of the ovulatory period again, so she's completed that annual cycle, LH is now being available again from her higher centers. And in that final wave, if you wanted to jump the gun and breed this mare earlier than she might ovulate on her own, at that final point near the end of vernal transition, she will respond to ovulation induction agents. So you could use HCG or deslorelin likely and get her to ovulate and maybe breed her a little bit earlier. So in my part of the world, the palpations and ultrasound that are done early in the year are necessary to avoid premature treatment with progesterone products. And you say, well, why would you do that? She's moving through transition on her own. But in breeds that use a universal birth date, the goal is to try to have the mares foal as early as possible in the calendar year, but not before. You don't want to breed them before February 10, February 15, because then the likelihood is they may actually foal before January 1 of the next year. And that means if I bred a mare that was cycling on January 15 and she foaled December 25 or 26, in 5 or 6 days, that December 25 or 26 birth on the calendar becomes a yearling, and it's considered to be a year old because it was born late in the year instead of that desirable January 1, January 2 birth date. So those are funny things that we have to deal with in this industry. But if you have a mare that's having a prolonged vernal transition, you can put her on a period of time on a progesterone product. It could be Altrinogest. It might be progesterone in oil that requires daily administration. It could be a repositol form of progesterone. And after she's been on that for a period of anywhere from 12 to 15 days, you can synchronize her activity to the degree that when you withdraw the progesterone, she's likely to come into a nice estrus. And if you can breed that mare, it might be 30 days earlier than she would have done on her own. So anyway, that really just sets the stage for what I wanted to get into today. So knowing what normal is, what goes wrong? What goes wrong with the mare and all of the management that we want to do with her? My intent is to discuss some of the more common conditions a mare experiences, including ovulation failure, clinical management of large ovary syndrome, and I understand very well that there are regions in the world where laboratory analyses are going to be unavailable, or it's just impractical to try to collect samples and to process those and get them to a laboratory in time. So I'm going to touch on mare uterine disorders such as delayed uterine clearance and some practical treatments that would hopefully be helpful wherever you may be located. And then after that, I'll review a little bit on broad ligament hematoma and some common disorders of pregnancy, and discuss briefly some factors associated with early embryonic death, twinning, and the assessment of the placenta in high-risk pregnancies. Once I get through that, I'll have a brief review of stallion pelvic and scrotal conditions that would have practical clinical significance for you. While many of you will be comfortable with scrotal examination and palpation of the testes of a stallion, fewer of you may have actually conducted or be familiar with transrectal palpation of the stallion. So the clinical cases that I want to present to you include ampular stasis, spermatic cord, also called testicular torsion, and some causes of testicular enlargement. So I would encourage you, if you've never done a stallion palpation before, if you have a horse that you can access, and don't use the most expensive horse on your farm, but if you can sedate an intact horse and conduct a transrectal palpation based on what we discussed today, I think it will help give you a better impression of what might go wrong with him. Geldings are less helpful because after castration, the pelvic structures by and large regress in size. Okay, so this is going to be a brief look at the use of ultrasound in the mare and stallion, and I hope I'm able to offer you some insights into using ultrasound more often than just for routine mare checks. So I'm going to begin with hemorrhagic and ovulatory follicles. And some of my images might not be the best, but when you are doing large numbers of clinical cases, you often don't have the camera at the ready, and sometimes you borrow images from other people to try to make your point. So we'll just see where we go from here. A hemorrhagic and ovulatory follicle can be quite large, clearly filled with blood, and it may or may not exhibit or develop luteinization of that follicular wall that you saw on those earlier ultrasounds. And the question is, why not? It may be estrogen deficient, or it could have this anovulation may have occurred because of insufficient GnRH release from the hypothalamus. They may also be a result of decreased pituitary LH secretion or synthesis, but they are most often observed during autumnal transition. But that doesn't mean that they can't happen in the ovulatory season, because they certainly do. And it compounds our breeding of many of these horses when we are so pushed to get mares pregnant in such a short, abbreviated breeding season for equids. Large follicles that occur during the luteal phase often become atretic, and this is similar to what happens with the development of secondary follicles that luteinize during a pregnancy, which is a normal thing at that time. If prostaglandin is administered to a mare that has a large diestral follicle present, so you're actually focusing on what's happening while she's in estrus, and you think, well, I've got a nice follicle that I'm going to breed this mare on, and if you don't do a proper palpation and you don't really know what's going on with her, And if she has a big diastral follicle, because mares have follicles all the time, about every 10 days, there's a new wave, you may actually induce ovulation in the diastral follicle. So instead of short cycling that mare and having her return to estrus, she remains out of heat because that diastral ovulation now results in a longer period of progesterone production. So if ovulation failure is determined to be related to season, whether she's late vernal transition or early autumnal transition, an ovulation induction agent may be all that's needed to try to have that additional opportunity to breed her that one more time if you can pull it off. And so this is not the best image that I had about an anovulatory follicle, but what I want you to look at on this one is that here's this luteal cell layer. But if this had been a video, which I didn't have set up that day, you can see kind of a murky content within what is the follicular fluid. And what that actually is blood within the follicular space. And the ovum that would be within that follicle was trapped. And so it's going to degenerate. And so you're not going to actually have any chance for conception from that one structure. So enough for that one. These really are in brief, I know. We're going to move on to large ovary syndrome. And what I want you to be able to do by the time we get to the end of this discussion on large ovaries is to be able to distinguish, just by using history and some common features between the different potential causes of large ovary in a very practical way. And what you're going to find is that if you don't have access to endocrine testing, it doesn't mean you can't do a good job. My intent is to address the initial ultrasound appearance of the ovary found to be abnormally enlarged, couple that with pertinent history of the time of year, her behavior, and any recent behavioral changes. Add to that your palpation findings of the uterus and cervical tone, and then an ultrasound comparison of the affected ovary with the size and activity of the contralateral ovary. Often by doing that, you're going to find that the diagnosis may become obvious. I remember in vet school, and that was a long time ago, I would hear things about a condition of such and such a thing. And the one thing that confounded me all of the time was sort of, oh, what are the reasons for large ovary in the mare? And it was just stuff to memorize. But there's a really practical way to address this syndrome that we have and to try to avoid removing a normal gonad. Because so you distinguish between normal and abnormal causes of enlargement, and there are some of each, and you do serial evaluations, a minimum of 2 exams. My preference is to have at least a 10-day interval between the 2 exams. By doing that, with my farms that have a lower budget and they are trying to save bucks where they can, I actually end up seeing the mare less often, fewer farm visits to bill to the client. I still gather valuable information, and I get to see the mare at 2 different time frames throughout that 21-day cycle at about a 10-day interval. The worst thing you could do, I think, at least in my opinion, is you have a mare that has a large ovary and the client's concerned because they think, oh, everything's a tumor. Well, it's not. But they push you into doing an ovariectomy because they want that thing out. You, as a responsible veterinarian, take that ovary that was removed and you send it off for a pathologist report, and it comes back normal ovary hematoma or normal ovary something else. And you realize you've done that mare and that client a disservice, and you're feeling pretty bad about yourself. So I want you to be able to avoid that, so that's not going to be an issue. So for each one of these factors or characteristics of a large ovary that we're going to discuss, I want you to start thinking about these features: the mare behavior, the duration of change over which her behavior has occurred, what season is it taking place in, Again, of course, what are your physical findings, both transrectal palpation and ultrasound, and then decide after you've collected that information, is an endocrine exam really necessary? Pretty expensive. And so you can look at the different laboratories that offer these exams, and we'll return to this on a subsequent slide. You can easily spend $100 to $200 trying to get a large ovary panel. Plus you have the overnight shipping of the samples. And if you can avoid something like that, if it's not absolutely critical, wouldn't that be a nice thing to do? So the primary rule-outs for large ovary syndrome in mares are going to be persistent follicles. We've discussed that those are present both in the vernal transition and the autumnal transition. You may see a hematoma, and a hematoma is a post-ovulation event, so that would be occurring during the ovulatory season. There is, of course, the most common tumor, the granulosa cell tumor or the granulosa theca cell tumor. But even though it's on the list of primary rule-outs, all tumors are rare. So don't forget that if you have mares that are cycling and a large ovary is present, don't forget that it is more likely to be a persistent follicle or a hematoma than it is the tumor. It's not that it can't be a granulosa cell tumor, but just don't jump the gun. You don't need to do that. So we're going to take a look and discuss first about persistent follicles. Persistent follicles found in transition are not ovarian cysts. They are follicles that fail to undergo final maturation and ovulation. On ultrasound, they'll have the appearance of a normal follicle. They're just larger and they live longer. They are most commonly observed in transition, and while they can be quite large, their increase in size is slower than a dominant follicle. So that's a key feature as far as what's the degree of change. Persistent follicles may respond poorly to ovulation induction until late in the vernal transition period when they're becoming steroidogenic, or on the cusp of the autumnal transition, they still have some of that capability. And if you do an ovulation induction agent, you may still be able to stimulate one more ovulation and opportunity to breed that mare before she slides farther into autumnal transition because her own LH is diminishing. So pretty easy to work with, and season and palpation findings are really helpful. Hematomas, so we'll look at the same factors. The keys to this thing, primarily an ovulatory season occurrence, and it generally, we think, occurs because of an excess of the heparin-like substance that's present in follicular fluid. The hemorrhage within that former follicular space continues to develop and accumulate longer than it would for a normal CH. A definition of a hematoma is a CH that becomes larger than the follicle that preceded it. A hematoma may just be a few millimeters larger than the prior follicle, or it may become as large as a basketball. It's the rapid stretch, though, when it comes to the behavior thing. It's not only that the mare was in estrus recently and she's now teasing out, so the hematoma as the cause of enlargement is relatively easy. History, recently in estrus. With ovulation, she becomes uncomfortable. It's that rapid behavior change post-estrus. In addition, while she may resist being palpated because it hurts, because of that stretched tunic and the pain she's feeling, you may also detect, if you can get her settled down enough to do a complete palpation, don't forget the other parts of her tract, you'll detect that she's having increased uterine tone. There's no endometrial edema, and her cervix is going to be closing or closed within 1 to 2 days of that event because progesterone is still being produced by this ovulation. And regardless of the size of the hematoma that develops, the luteal cell lining of that follicle is still capable of producing progesterone. If she was bred on the cycle that results in the formation of the hematoma, pregnancy, if she was bred, may continue without complication. But if she fails to conceive, the hematoma will not be responsive to prostaglandin in that normal 5-day time frame that you would think for a normal CH moving into a CL that's mature enough and will allow her to be short cycle. A hematoma is going to require longer to luteinize, so prostaglandin injection to bring her back into heat so you can make another breeding attempt will often have to be delayed or not work for 2 weeks or maybe even longer after the hematoma develops. So that can be frustrating. But what you can also do if you're not in a rush is just, I called it my large dose of leave alone. You can just let her go through this on her own and it will clot and contract over time. On ultrasound, that hematoma, instead of having the clear black fluid that you would expect on ultrasound, it'll often look like it has little speckles, kind of a ground glass appearance. And that's the hemorrhage that's filling that space. But it will luteinize and clot and contract and diminish some in size over time. Then we get to granulosa cell tumors. So it's a tumor. It can happen any time of year. There are 3 primary behavioral manifestations that we know go along with a granulosa cell tumor. The vast majority of those mares are going to be very passive. Their behavior will be similar to a gelding. It's as if they remain in a persistent winter anestrus. Smaller percentages of the affected mares with the granulosa cell tumor will exhibit a persistent estrus, and a few others are going to have stud-like behavior. That might include not only increased aggression, but sometimes you'll have very stud-like vocalizations. Most granulosa cell tumors have a really classic ultrasound appearance. They have multiple fenestrations, and they look like Swiss cheese. I'm sure all of you have seen pictures of those either on ultrasound or in books. Occasionally, the fluid accumulation that I found in tumors that have been removed will, instead of being fenestrated throughout, will actually just be a large fluid-filled space, and it just looks like a ball. But after ovariectomy, there's usually at least one small area on the periphery of even that kind of different or less usual granulosa cell tumor. You'll find a little area that has small pockets of fluid within the wall. What occurs with these things that makes the behavior so dramatic and the opposite ovary decreasing in size and activity is that this production of anti-Mullerian hormone and inhibin actually inhibits FSH in the higher centers. And that's what causes the activity of the contralateral ovary to become suppressed. If the tumor is not removed, over time that contralateral ovary becomes less active, it becomes smaller, and finally really inactive, and they can be quite tiny and hard to palpate. So depending on how long that big ovary was either known to be there and left alone, or the clients didn't do anything with it because they weren't aware it was there, the contralateral ovary may become so suppressed that its return to function after ovariectomy may either be delayed or in a few cases will be permanent. So in addition to the Swiss cheese appearance on ultrasound, the other cues that you can look for with your records to try to put the picture together is because the granulosa cells are literally at the center of this tumor, the ovulation fossa that is so apparent on a normal palpation, that area of the ovary may fill in. And so that definition is lost and the ovary just feels round. So that's one of 2 things that can actually cause a filling of that area. The granulosa cell tumor is one that's a permanent one, whereas the other one is a transient finding. But the surface of these ovaries is kind of smooth undulations. It's not really, it doesn't have any sharp, odd features to it. And about the best thing you can do for that mare, if it's not horribly large and hasn't been there for years, is to do an ovariectomy. So these are some images that I have collected over the years. The one on the left-hand side is the classic ultrasound image, and this one, these are centimeter markers on the side, again, was about 15, 16 centimeters. This is a fairly typical view of this one, kind of an ovary that's been cut in half. You can see all the fenestrations and the little pockets of fluid on the periphery. This one just happened to have a big blood clot in the center. The one on the far right, though, is the biggest granulosa cell tumor I've encountered. It was about 1 meter across, and it weighed just shy of 100 pounds, so 44, 45 kilograms. And you can notice on this, the surface, just big, smooth undulations. And I can guarantee you there was no ovulation fossa left down here. That was long ago lost on this one. Okay, then we look at some secondary rule-outs for large ovaries. Teratoma is one, and abscess, and then dysgerminoma is on the list, but I don't have any pictures of it because generally by the time people find out that the mare had a dysgerminoma, it's actually on a post-mortem because it presents atypical compared with all of the other tumors. It metastasizes early, it goes to the joints, and you're trying to treat the mare for lameness when indeed it's really a metastatic tumor that has already doomed that mare and led to her fate. So we'll take a look and talk a little bit about teratomas, and teratomas are actually pretty cool. It's one type of a germ cell tumor. They don't generally metastasize. Their contents can be highly variable. They can be filled with hair, like this example in that picture. But I have been ultrasounding some ovaries, and you'll see a molar. So there's a tooth there. Or sometimes it's a meniscus and bits of bone, joint fluid, everything else when you cut them open. So whereas the external surface of the granulosa cell tumor tends to be smooth or have rounded lobulations, teratomas can sometimes develop little odd shapes and protuberances. They're not sharp, but you'll notice that they're just slightly different than what you would have expected. So it's usually an incidental finding. It rarely has a huge endocrine profile that leads you to believe that she's an aggressive mare because of a teratoma. I'm not saying it can't happen, but it's certainly not the norm. And then there are instances when you may actually find an ovarian abscess. That would, of course, again, be any season. The opposite ovary would not be affected unless it had also been damaged in the same way. Her behavior, if it's one-sided, is going to be normal because she'll still cycle on the other ovary. On ultrasound, and it surprised me on this one when I had this case, because on ultrasound, it just looked like a big follicle. The black fluid nature of that ultrasound, I thought, well, must be just a large persistent follicle, is something odd, but it never went away. So we removed this. And how anybody can explain to me, I would love to know that you can have this creamy, nasty stuff that was filling the entire core of this ovary, and it looked like that, and yet it was perfectly black on the ultrasound appearance. I found that just quite puzzling. But anyway, history is going to help you because generally, if you find out what's happened with this one, there's often been some kind of invasive procedure, usually an iatrogenic thing, by someone poking needles in ovaries, and whether it was to do a sample technique or maybe aspirate an ova, I don't really know. But they always seem to have some advanced reproductive technology and or other things that were done to it that lead to this being a developing problem. So the endocrine profile, probably not necessary to spend money on that. You can save your client some money on that one too. So with those common, most expected causes of large ovary, you can assess the pieces of the puzzle, the information you collected, season, T's and behavior, behavioral changes, palpation, ultrasound, and only when you've completed all of that do you maybe even consider at that point doing some endocrine testing. And I've often found out that I just don't even have to deal with that at all. And I come to a satisfactory conclusion with what's there. So ultrasound imaging really helps me kind of get those most important pieces of the puzzle, because If there's a large ovary and it's not seasonal and it's a persistent follicle, if it's not a hematoma, then I know that granulosa cell tumor, however rare they are, is going to be probably the next thing that I want to consider on my list. Okay, a little bit on uterine disorders. And I have a inclination to find odd things. I love pathology. If something has gone wrong, I kind of get a kick out of finding things. But sometimes you learn that some of the oddities that are there are actually really problematic, and you're not supposed to enjoy them. You're supposed to help the mare and get her fertility restored. But lymphatic cysts can increase both in size and number as mares age. They are a fact of life. It would be really rare to find a mare that it is her mid-20s that doesn't have a significant number of lymphatic cysts. But if the size of that cyst becomes really large, it has the potential of blocking transuterine migration. And this is an image that I collected a few years ago because I find it absolutely fascinating. And if you take a look at this, the ovary on the one side of this mare was really small and regressed, essentially non-functional, whereas her other ovary was really large and it had beautiful follicular activity, and they could never get her pregnant. So we had done an ultrasound of this mare, and maybe it's, I was glad to get the tract so I could prove my point, but this mare actually colicked and had to be put down for another reason. And I said, can I please have her tract? Because this was one of those cases during her life. Had this been recognized early on and had been addressed, she would have probably had normal transuterine migration of ova that reached the uterus. But in this instance, the lymphatic cyst was so large, the conceptus probably only had a portion of a uterine horn, in which they tried to let her know that there was a conceptus there, so please don't dump prostaglandin and short cycle. But that's indeed what was happening with this poor thing the whole time. And it precluded her actually establishing a pregnancy. So how big is too big? In my hands, if I find that at the start of the season, since I always encourage my clients to have that mare be palpated and having an ultrasound done at the start of the season, I want to know what's there. She's middle-aged or older. She will have lymphatic cyst present. If I find a cyst that is greater than 35 millimeters diameter, I recommend eliminating it before the breeding season begins. The cyst may recur, it may refill by later in the year, but by the time the pregnancy is established, it won't have any effect on the development of the pregnancy as it is. Otherwise, you find out that when you breed a mare, if she has lymphatic cyst, it seems like every single conceptus, as it goes through transuterine migration, wants to put up shop and live next to a cyst. And so it can be problematic, and you'd like to reduce that likelihood so that you will increase the likelihood that she will conceive and maintain a pregnancy. So in doing that early season exam of palpation and ultrasound of that mare, I have a small outline of a uterus with the uterine body, the cervix, and the horns on my mare record. And I will create what I call a cyst map. And you want to mark down the location and the number and the size of the lymphatic cyst that are present in that mare before you ever start the breeding season. And ultrasound is honestly the best means to gather those details. That way, consider that mare has been with you early on. You took care of any cyst problems she had. She's bred, and now she's brought to you for an early pregnancy exam. You won't be inclined to mistake that lymphatic cyst for a twin. And wouldn't it be a shame if you had two circular structures, two little vesicles, and you decided, oh, she's got twins, and you crush the one and the other one never grows? It meant that you had a unicornual pregnancy and a cyst, and the cyst is happily there, but unfortunately you eliminated the pregnancy. So that pre-season cyst map is going to be really, really helpful. Without a cyst map, a first pregnancy exam could be of a single conceptus and a cyst, but if you know which one is which, it allows me to avoid waiting that 1 to 2 days for the conceptus to grow as it does quite rapidly, and to be able to distinguish it from a lymphatic cyst. So if I have the records, I can actually do my client a much greater service. A cyst, again, isn't going to grow, if not only just very slowly. It's very easy by doing that to distinguish it from the pregnancy itself. So lymphatic cysts are not the greatest, but they can be dealt with. The causes of delayed uterine clearance, we call them duck mares, can vary widely. Luminal fluid can be a reflection of an infection. Could be that her vulvar conformation is less than ideal, permitting her to suffer from wind sucking and contamination of her tract. She could be an older susceptible mare that's incapable of mounting an appropriate response to inflammatory products that were introduced into her genital tract during breeding. Fluid that has been recorded when she's in estrus leading up to ovulation should be noted. Its volume can be estimated, and any characteristics, flocculence or swirling, whatever you see, make a note of that in your record. And considerations then should be given whether you want to do pre-breeding lavages, if you think maybe you can get away with just doing serial oxytocin administration with the intent of either diluting the fluid that's there or eliminating it. The last thing you want to do is breed a mare that has a uterus filled with who knows what, and then 5.5, 6 days after ovulation, the conceptus arrives into this polluted environment, and it makes conception quite difficult to even imagine. You may decide, if you see fluid, as is on the left-hand view of this screen, to delay breeding. Or you can breed a mare and follow it with a series of oxytocin administration or uterine lavage. Those are the arts of practice that you have to figure out what is best in your hands. This mare had a uterine flush done, and you can see how cloudy was the fluid. We cultured the fluid. It was a beta hemolytic strep, which is the organism that causes probably 85% of mare infections. And then you had to decide how are you going to manage it and treat it from that time on. So if we have a problem not with a chronic infection, but if it's really poor vulvar conformation and it's otherwise a younger, healthy mare, it may be that you can just take away the source of the irritation and she will readily clear on her own. A timely Caslix vulvoplasty done after breeding and put in place no more than 48 hours after a confirmed ovulation may be all the treatment she needs. And so by putting that Caslix in, it will diminish further inflammation to her tract caused by wind sucking, and the fluid accumulation will often disappear within 1 or 2 days. Sometimes maybe it'll take 3 days if it's been going on for a long time. And by accomplishing that, the conceptus, when it arrives, will arrive in a much more hospitable environment by the time it arrives in the uterus. So the best way to actually manage that mare is to try to figure out, whoops, went on prematurely, to monitor that mare. And the progress you're making with your treatment is with ultrasound. It's just an incredibly valuable tool. Small amounts of fluid that might otherwise be undetectable can be treated with multiple low doses of oxytocin. And I generally use 10 international units IV or 20 international units IM, or cloprostenol. Cloprostenol will get you some sustained contractile activity for about 6 hours. And the dose I use on that is 250 micrograms, and that's administered IM. And I start that treatment in this fluid environment that I want to resolve, starting about 3 to 4 hours after the mare's been bred, or whether it's live cover or artificial insemination. And that will actually result in a diminishing of the fluid that's in the lumen and improve the intrauterine home to be for the conceptus. So ultrasound monitoring, again, using it, I mean, if you've got the machine, use it. It can actually reveal sometimes that the ecbolics or lavages that you've been using to treat a mare that has fluid accumulation maybe are insufficient to resolve the problem. And it may be necessary to collect a uterine culture and request a sensitivity and plan on doing uterine flushes, followed by local antibiotic administration. Again, you're monitoring progress by the use of ultrasound. Luminal fluid after breeding or a lavage will be gone from the normal uterus, and that's the normal uterus, within 3 to 4 hours of whatever the procedure was done for breeding or otherwise. If on ultrasound you detect residual fluid after 3 or 4 hours, then serial ecbolics like oxytocin can aid in its removal. But left in utero, if you don't treat it, if you don't treat the fluid when you see it, that fluid can actually become a wonderful bacterial growth medium. So there are reasons not to just say, oh, she's got fluid, it's not too much, I'll just let it go, when indeed it might be exactly the wrong thing to do. If, on another hand, a mare has endometritis or a long-standing contamination of her tract, or she's been overtreated with antibiotics, conditions that may be present that started as a simple fluid accumulation may result in the development of a biofilm that's going to be much more resistant to uterine flushes and probably not respond to in utero antibiotic installation. The treatment for a biofilm and the care for that mare fall outside the goals of this lecture, so I refer you to papers and proceedings on that topic. Regardless, ultrasound monitoring of her status with each exam continues to be a very valuable tool in your hands. And unlike with cattle, a mare can have a pyometra, and a pyometra could look just like this. The walls of the uterus can become very thick. But usually, as long as she has some drainage through her cervix, she's going to otherwise appear quite well. She's not going to be a sick mare. It's not like a bitch with a pyometra. Some mares, though, over time, will develop cervical induration. The cervix becomes rock hard and incapable of relaxing. And if you start monitoring those mares, you realize that they are becoming a little less comfortable, maybe. Spontaneous drainage is no longer possible. And so you monitor those mares with palpation and ultrasound, and you may need to actually assist her with cervical dilation to remove some of the content or to attempt uterine flushes. So if a mare has a pyometra, her return to breeding sound condition is probably less likely. But if the owner is insistent upon attempting treatment, my suggestion to you would be, if you see something like this image, begin with a culture, seek sensitivity to identify the best antibiotic if there is one, but also consider one additional task. Consider collecting an endometrial biopsy, since over time, any chronic fluid accumulation like this can really diminish the quality of the endometrial biopsy category that this mare has in her endometrium. And an individual that has, in actuality, no breeding future, she may not even warrant the cost of treatment. But there are plenty of mares out there that live long and well with an untreated pyometra, so it certainly is not any death sentence. That's not a big deal. Okay. Broad ligament hematoma is commonly observed in mares 12 years and older. Hematomas can be unilateral, or like in this image that was actually on table in necropsy, tells you how that outcome went. It may be, two-sided. So here we had accumulation of blood both to the left and right side of the uterine body. You can tell that this mare was a few days postpartum, because here's her formerly gravid horn, and here's the formerly non-gravid horn. And she was actually involuting beautifully by the time the hemorrhaging began. So the hemorrhage from this hematoma lies between the thin layers that comprise the mesometrium, and it can result from rupture of the utero-ovarian, middle uterine, or external iliac arteries in the peripartal period. Some mares will actually have a bleed of this sort in the days leading up to parturition, so it's not like it doesn't occur. Hemorrhage accumulates, and as long as the mesometrium remains intact, the mare may survive. And indeed, many cases go undetected until the mare's just having a routine exam for breeding in that next season. And upon examining her in that peripartal period, you feel the uterine body, and off to either one side or both sides, you feel there's a little filling defect. Instead of going from the uterine body onto the broad ligament to either side, it actually lifts up, and it tells you that there's something that has accumulated within that space. Your plan? Man, cease your palpation. Keep the mare quiet. What you want to do is leave her alone. Let the blood that has accumulated within the broad ligament clot and contract over a longer period of time. You can gently track how it appears with ultrasound, but your goal for that mare at that time is no transport, no palpation, and her activity should be restricted for at least 2 weeks. And you want to really not be the partner in crime if you are curious and you want to do an earlier palpation and you end up rupturing and tearing through the broad ligament and the mare dies. So the client says, well, doc, how do I prevent this in the future? And there's only one way to prevent a broad ligament hematoma from not occurring again in the future. And that's to me, that is that you don't breed that mare again in her lifetime. That the elasticity of the vessels that she has that are supplying this area have actually been lost. So in the loss of elasticity, she's going to be predisposed to recurrence, and breeding, unless that's the only job she has that has any value, should probably not happen again. When it comes to involution, now that we have a tract here where you can actually see how the uterine horns are coming down, it's an appropriate time to just briefly mention full heat breeding. And transrectal palpation and ultrasound are really valuable in assessing postpartum involution. Whether or not the lochia is still present in the mare, it should be gone by 6 days postpartum, but occasionally pooling of fluid will continue longer. And you can decide whether a mare is a good candidate for full heat breeding. If a mare, in my hands and on the farms I work with, if she had an unassisted foaling, uncomplicated, so no dystocia, no retained fetal membranes, she delivered a viable normal foal, and has a normal lactation, then I move on to transrectal palpation and ultrasound to help determine if she really is that good candidate to be bred on full heat. My intent is not to breed a mare that ovulates prior to day 9. And the reason for that is it takes about 15 days after the mare foals for the endometrium to sufficiently recover from that pregnancy to readily be able to sustain the next pregnancy. So if I breed her on day 9, or I could breed her on day 8, if I'm pretty sure it's going to be a day 9 ovulation, that means if I give a nod to the time for tubal transit, that will take 5.5 to 6 days. Breeding on day 9, it won't arrive in the uterus until day 15, by which time the endometrium should be willing to start it all over again. So your ultrasound exam should confirm, these are the palpation parameters that I use, that the former gravid horn, by the time you get to 9 days, should be no greater than 15 centimeters in diameter. A dominant follicle would need to be present, as well as endometrial edema, and I would be looking for at least 40% relaxation of the cervix. So one other thing to remember and keep in mind, and when I first started doing a lot of mare work, north of Columbus, Ohio, in my residency. I was just astounded at the size of foal heat follicles. A mare that would routinely, in every subsequent estrus she'd had, would have a dominant follicle, maybe 45, 50 millimeters, of size, and yet during foal heat she could have an 8-centimeter follicle, and it just blew me away how big they could be. But that's just the nature of foal heat. So it's how it is. Okay, leiomyoma is the most common tumor of the wall of the uterus, and this one is an image from the Atlas of Equine ultrasound. They can often just be part of the uterine wall itself. This is one that was actually intruding on the lumen, and I had a similar one to that a number of years ago. But just be aware of the fact that if you see it, you can monitor it. They tend to be slow growing, and just allow the pregnancy, if she's underway, to continue. Depending on the location or size, the amount of myometrial tissue involved, subsequent breeding could be discussed with the owner, but if it remains small, it's probably of lesser consequence, so you don't really need to give it a whole lot of your time and attention. We'll go ahead and continue with some of the disorders of pregnancy. The common ones, again, would be early embryonic death. Of course, twins is such a big issue in horses. A little bit on placental disorders, and then the combined thickness of the uterus and the placenta in recent years has become a good means of trying to determine the health of that pregnancy later in gestation. So what I have here are some normal and some abnormal pregnancies. I'll just play these first. And I had, this one was absolutely normal. So we have the allantoic space below and the residual yolk sac up above at about 35 days. And this was a perfect pregnancy. It was going right along very well. But I have found, at least in my hands, that the causes of early embryonic death are very similar to those of conception failure. Could be a defective embryo. It could be an existing endometritis that's creating a hostile environment for the conceptus. Maybe she's got a poor endometrial biopsy category and she's unable to establish adequate placentation. Could be an endocrine disorder, could be maternal stress. There's so many things like that. But what I want to do is, as a clinician, look for some abnormalities. And I'm going to get to the one on the right here in just a second. But I suggest to the farms where I work that I would like to see these mares at least up until embryo heartbeat, 25 days. And then if that mare is resident on the farm, I'd like to have her back in my hands at least every 10 days. And up until day 50, because most pregnancy loss in mares occurs before 50 days of gestation. The earlier you identify that pregnancy has been lost, the sooner you can do a proper diagnostic workup, and it allows you more time to rebreed that mare within the same season. So in my practice, and this has happened to me numerous times now, I have detected a higher rate of early embryonic death in vesicles that are rotated from that normal dorsoventral orientation. And so I found this one example, and this is one that was actually on its way to termination. And I don't know exactly why, but I have kind of an impression of what's going on. And I would love it if anybody wants to disagree with me or give me another reason why this may be occurring. But early in development, the area of the chorionic girdle of that 34, 35-day pregnancy, it's oriented, it should be oriented for best attachment to the dorsocaudal aspect of a uterine horn down near where it goes onto the uterine body. If it's oriented off to the side, you can't do anything about the orientation at that point in the pregnancy, but you may wish to put a mare like the one on the right on your more frequent checklist. So when you take a look at this one, instead of having this portion of the embryo be dorsally, and again, here's the allantoic space, and we have yolk sac towards the right-hand side. This one is off to the side. We still have a heartbeat, if you notice, in that early embryo. So the heartbeat's still going, but we have dramatic increase in endometrial fold edema. And this is one of those features that I've seen in these pregnancies that are rotated off to one side. So this is day 35 on this side. And if you look at the endometrium, when this is open, very little dramatic endometrial change around this. And here's one just 3 days older. And yet the endometrial lining is just really imposing on the space of this poor little thing. And it was on its way to its own destruction. Okay, it's not cooperating with me. Here we go. Okay, the other thing that you can do with ultrasound that is really very helpful is take a look at features of fetal viability. And so heartbeat clearly is one of those things that everybody wants to look for, is what's normal or not. This is a 42-day pregnancy. And so as you can come through, you can see the embryo is here. It's developing quite nicely, but you can see a nice little heartbeat here in the center. Same thing down here is a 50-day gestation. And you can see the nice little head of the fetus at this point. And in the thorax, we have a lovely little heartbeat going. And it's clearly moving, it's viable, everything looks good. Later in gestation, we can look for a number of different anatomic features of a later stage gestation, and different people have documented what is a normal size based on some breeds of horses. But what you can notice on this one, it's a means of actually assessing the orbit, and on this one you can even see the lens within the eye of this fetus that's nearing term birth. But by measuring the eye, you're able to determine if indeed we have normal development for the stage of gestation. So as we go through this, what I'd like to have you consider doing is, even though you don't normally have a reason to check a later stage gestation by ultrasound, you may be doing palpations, you find the cervix is nice and tight, the uterine body, everything else feels good. Poke your ultrasound in there. It's amazing what things you can find, and you might want to just take a look and challenge yourself on other things that are happening in there. Okay, this is, well, two things are going on here. The one on the left was a mare that had twins. Her name was Miss Clairol, and this was a 25-day pregnancy that we had detected twins at that point. And so I had done a crush of one on this side, and you can see how it's a little bit smaller than the one over here. They were both pretty unhappy. And one of the common occurrences with twins is that the mare tends to reduce one. So it goes back to a singleton pregnancy. But if they are allowed to go on their own, and if they're bicornual, there's one in each horn of the uterus, they often continue developing farther. But the uterus at some point says, yeah, you know, this isn't going so hot, and she will reduce one. In this mare, she wasn't reducing one, and so even though this one looked quite unhappy and the surface was quite irregular, the embryo here was doing better. It had a better heart rate, and so we did a crush on this one, and this was just a follow-up measurement, and it had become more irregular. We had actually dispersed the fluid from the prior crush, but we're just monitoring it to make sure that it actually did complete its own destruction. And then we have the one over here that was normal, and it actually looked better than that previous one. And within a few short days after this, with this endometrial edema that was beginning, this was a pregnancy that was lost. We have since found in Michigan, and it was quite disheartening, that with some of the chemical plants that are located in the northeast part of the state, you can't take it to court, you can't prove actually what's gone wrong, but we actually thought we had some endocrine disruption with the water tables that were close to this farm that may have actually led to the demise of some of these pregnancies and the resultant endometrial edema and pregnancy loss. So twins are undesirable in mares. Most twins undergo, as I said, a natural reduction, and the remaining embryo just continues on its way as a singleton pregnancy. But if natural reduction doesn't occur by day 40 on its own, the typical history that you will see on a farm, and if you've just taken on a new client, you don't have any idea who did the work ahead of time, or maybe they just did live cover breeding and the mare's never been palpated. But the typical history of that mare with twins that has not reduced early on is that she starts developing premature mammary development by 7 to 8 months gestation and essentially aborts after that. So to avoid losing a year in the productive life of that valuable brood mare, reduction of one or termination of both and breeding on a subsequent cycle is certainly more desirable than losing them all. If you have, excuse me, and this is another example of a mare that had asynchronous ovulations, but this is an ovary. And here's one ovulation that's a little bit older, so a CH turning into a CL. And here's a second ovulation, so we have the nice luteal rim and a fluid core. They were about 48 hours apart, developed twins, but because they were asynchronous ovulations, internal reduction didn't occur. And so we had to go ahead and actually do a crush and to remove one of them so that we were back to a singleton. If on your palpation you find out that you have two concepti that are side by side, as long as there's some separation between them, you can actually milk them apart slightly and try to do a crush of one. I usually try to do the smaller of the two, not that I can prove that it makes the difference. Clients will often say, "Doc, leave the colt, I want the filly," or vice versa. And you tell them it's exactly what you've done, because by the time it's born, either they won't remember what promise you made, or it doesn't matter. They're just happy to have a life full. But their twin pregnancies can present many different ways. This is one, if you were just doing a quick ultrasound, you'd think, wow, that vesicle is a little oversized, but I'm sure it's normal. When indeed on a better look, you can see you had two vesicles, one superimposed on the other in a unicornual twin pregnancy. That would be hard to actually reduce because of the close proximity. This is another one that kind of looks like a budding candida, and yet it was two vesicles, little barbells sitting right beside each other. Up here we have not only that unicornual twins, but there was a third vesicle over here at the sides, but that was actually a lymphatic cyst. And then, unfortunately, this was my mare, and it was a free breeding to a really nice warm-blood stallion, and so when she developed twins, I couldn't get another free breeding, and I let it go out, and she didn't reduce until 57 days of gestation on her own. I was going to allow her to get to 2 months and then terminate it, but she actually finally cooperated. The final image down here are bicornual twins turning the transducer sideways. I could get those images, and in this instance, we went for a crush of the smaller of the two vesicles. So as long as you have a separation, you can usually adequately do a nice crush of that twin. But here's something to keep in mind. You want to do this as early as possible in pregnancy. The farther along this mare is pregnant, the more manual pressure it's going to take in your hand to crush one, thus increasing the likelihood the bigger it gets, it'll take more hand pressure, and you have a greater likelihood of causing endogenous endometrial prostaglandin release that it's probably going to serve to terminate the other conceptus anyway. So the earlier you can identify twins are present and address them, the better off you're going to be and the greater success you're going to have in having one of them survive. This is an example of what happens with pregnancy that is lost due to twins, and it's usually because of placental insufficiency. In this instance, actually the foals both survived, but they were midgets compared to what they should have been with a 1,000-pound standardbred dam. And we had a beautiful halving of the uterus. Here's one uterine horn of the chorioallantois. Here's the other uterine horn and half of that. But this whole white area was the area where the two twin placentas were in apposition to each other, causing a loss of nutrition, and removal of waste material was also diminished. That led to the smaller size and less uterine occupying space available to each one of these. If you have Twin placentas, for the most part, you're going to have their own, each will have its own umbilical cord and amnion, and they're very rarely within the same space. This is usually the outcome you have with twins and horses, and it's not something you want to see, but if it happens, just recognize it for what it is. One usually dies, and then if there's enough cervical inflammation based on the location of one twin, then the other one is probably not too far beyond that for also dying and being lost. I've had 3 cases where the twin that was near the cervix passed out and was dead, palpated the mare, found that the other fetus was still alive, put that mare on high doses of altrinogest, got the cervix to close, and in those 3 instances, the second fetus actually was able to survive and continued to term. So sometimes you have good things happen and you wish it happened more often, but often it does not. Okay. Karen Wolfsdorf, Dr. Wolfsdorf at Haggard has written a lot about the craniocervical dislocation. It's another means of twin reduction if it has been missed by earlier exams, and it's actually a dislocation of the first cervical vertebra from the cranium. Again, monitor the progress and the success of your procedure by ultrasonography. And so it's another technique, it's another option you have if those earlier reductions were not done in a timely fashion. Just a word or two on the CTUP measurements. There are numerous papers out there on this, and the CTUP measurements, the thickness of what you expect to find, will always be a measurement on the ventral aspect of the uterus, and it's the combined thickness of the uterus and the placenta. So here we would have the fetus in this space where you could see the allantois and the amniotic fluid compartments. You'll see sometimes the amniotic membrane and the fetus coming up to meet you. And this is what it looks like actually on the ultrasound itself. So here is the location for the internal cervical os, dorsal aspect of the uterus, and about a wrist depth down on the ventral surfaces where you want to measure the combined thickness of the uterus and the placenta. In addition to that, those viability measures that will helpful for you to know how the fetus is doing will include observing it long enough to appreciate both its resting and active heart rates. The size of the fetal orbit can be measured, and there are other measurements for other body parts too that are known, and you can be referred to those by other textbooks or individuals who have an interest in that. Suffice it to comment here, the CTUP measurements can provide evidence of placental compromise. In addition, assessment of the placenta late in gestation may actually be one way of revealing signs of placental detachment, putting the entire pregnancy's safety at risk. And it may then cue you in that this mare needs to be observed much more closely for premature or difficult delivery or premature placental separation. And it may also help you establish that you need to consider pregnancy type treatment, whether it's with altrinogest, antibiotics, drugs that are going to actually slow the activity and the irritation of the uterus to try to gain you some time. The best place for that fetus to develop is in the uterus, not externally when it's not yet mature. And it needs to be within about 5, 6, 7 days of its term birth date to be able to survive and have adequate surfactant. So what we're going to do now is shift a little bit to the stallion, and we'll talk about some things. Oh, I forgot I had one more CTUP measurement here, and we had some separation on this measurement. And this is actually a reminder for me that you want to take multiple measurements. And this is the same mare, the same day, and within 4 minutes of each other, depending on where you were and how careful you are, take repeated measurements to make sure that you actually see what it is you want to measure and that your measurements are consistent. So before we review just a few conditions in the stallion, I want to provide a brief review of pelvic and scrotal anatomy for the stallion. Again, it's likely that many of you don't routinely do palpations of the stud. This is an entire reproductive tract from a stallion, from the penis all the way up into the pelvic structures, through where the the internal inguinal rings would be, down past the spermatic cord to the testes and the scrotum. And that way you can see the epididymis and all the structures. What I want to focus on in these next few slides, though, is what's happening in this area. So here we have bulbourethral glands. You can see where the prostate is, the seminal vesicle on dissection. And here is this really dramatic change between the ampullae and how it tapers down dramatically into the ductus deferens that dips down through the internal inguinal rings. So the bulbourethral glands are not palpable unless they're grossly abnormal. They're located just caudal to the pubis, to the left and the right sides of the root of the penis. And depending on the stimulation of that stallion to a teaser mare, before you've done your collection, they may or may not have really distinct visible fluid in their centers. The prostate has a very distinct appearance on ultrasound, and it's really wrapped nicely around the root of the penis. The more cranial paired seminal vesicles, and then medial to that, these ampullae are paired, both paired structures. Let's go back. And the ampullae are what you really want to know, what the sperm reserves of the stallion, that they have the reservoirs for spermatozoa that are emitted at an ejaculation. So scrotal palpation and ultrasound of that stallion provide you an opportunity to assess the size and the consistency of the testes as they lie on a horizontal axis. You have additional structures that you can look at within the testes themselves. You can look at the pampiniform plexus that lies dorsal to each of these of the testes. And that's the countercurrent cooling mechanism, so that the testes are about 5 to 7 degrees cooler than body temperature. You want to look at the tails of the epididymis, both sides, and again, just confirm during your palpation that both of the testicles have free movement within the scrotum itself. All of those are just important features. So on ultrasound, you should have a nice, normal, uniform appearance of the testicular stroma. Central veins, some of the other structures that you may see with the reedy testes will be apparent. And at that dorsal caudal aspect of the testes in the spermatic cord, you'll see the lovely little loops of the pampiniform plexus, all very normal in their appearance. So I didn't have a good image that I could get for this one for you, but I wanted to discuss in brief. We've got about 5 minutes to go. I hope I'm not running over too long. But ampullar stasis is where the sperm accumulate, and some people call it sperm stagnation. And that means that the sperm and glandular secretions are accumulating in the ampullar crypts. This results in inspissation of the gland contents, and that glandular portion that is normally about thumb diameter of the ampullae becomes really distended to the point that the stallion can be quite uncomfortable. If left unchecked and if it's not treated, it can actually completely result in blockage of sperm flow. It doesn't happen, as we used to think, only in older stallions, and it can occur at any age. Attempted semen collections are often characterized by a high percentage of spermatozoa that may be observed to have detached heads. You might see high sperm concentrations, but really terrible motility, and then you can see clumping of spermatozoa too. So what do you do with these things? Because now if you want to palpate the stallion, how are you going to resolve this thing? He's a valuable horse. You're trying to get some more offspring from him. Management of this condition is multimodal. Transrectal massage of the ampullae to dislodge the occlusion. Administer either oxytocin or prostaglandin to increase smooth muscle contractions. Many stallions will be really uncomfortable or unable to ejaculate until the massage and treatment are accomplished. But It happens if you can, I'm sorry, I lost my train of thought there. But if you do the management of this correctly, he will go from being very uncomfortable and unable to ejaculate, but after massage and treatment are accomplished, what you'll see within the collection vessel of that collection may look almost like strings of toothpaste out of a tube. And it can be this accumulation of very thick dead spermatozoa. So this is a left and a right side of the two ampullae of this stallion with a very small central lumen. And these thick walls are all of the accumulated spermatozoa within those the ampullae. So because it can recur in an individual, once a horse has had this happen to him, it may happen again. And so if you get them opened up and things start to flow, sometimes you have to do daily collections, and in a few individuals, 1 to 3 times a day collections are necessary until the semen parameters stabilize. The affected stallion may have to be collected regularly throughout the season, even if he doesn't have any mares ready to be bred to him. And there are a few horses where you actually have to continue year-round collections of a stallion like this to keep them unblocked. Spermatic cord torsions are a real thing in horses, and they can absolutely be devastating. This is a case of mine where the horse, when he arrived, had a stone-cold dead testes on the one side. Intra-op, you can see how tight was the constriction where the vascular flow to the testes had been completely blocked. And I'll often have horses that are brought in for a soundness exam, and you'll find a 180-degree flip of the spermatic cord of testes on one side. And I'd ask one of my students, oh, feel this, I want you to know it. And they'd palpate and they say they're both in the right orientation. And that's how readily some of these can flip. The big challenge occurs and it's much more acute and dangerous for the health of that testes, if we have a rotation that's more than 360 degrees, which places the spermatic cord on scrotal palpation back at its normal cranial location, but you have this extraordinary vascular compromise of the spermatic cord itself. So in this instance, this clinical case, by the time we derotated this thing during surgery and took it out, we actually had a 540-degree rotation. It had been going on for a long time. Only then did the owner admit that this horse had periodic issues with discomfort. And it's like, oh, horrible. Okay. This is just another case that Dr. Dabari shared with me that it had less severe consequences. We thought it wasn't torsed quite as much, but nonetheless, the testes had been killed off by virtue of the torsion. These are examples of a horse that had a torsion. And so here's the pampiniform plexus of a normal testes. Testicular stroma looks pretty decent, but on the side with the torsion, the pampiniform plexus was becoming less obvious, and the testicular tissue was clearly becoming damaged and harmed by virtue of the torsion itself. And I'm not forwarding. Here we go. Just a few other things that may cause scrotal enlargement or other harm within the testes. Traumatic injury can be a big deal from a breeding accident. I've had stallions on their very first mare they ever covered in their life as a 3-year-old were kicked in the scrotum, and the tunic around the testes just exploded, and on scrotal exam, it looked like shards of glass within there. But this is an example from Dr. Tabari of a testicular abscess, pretty dramatic in its appearance, and clearly no normal tissue left that could really be salvaged for his future fertility. In these instances, if you have the skin is still intact of the scrotum, cold hydrotherapy may help some of these individuals if the damage is somewhat less severe. But when you do hydrotherapy, it should not exceed 20 minutes per session, but you can repeat it about every 2 hours. You can also use anti-inflammatories such as phenylbutazone or Flinix and meglumine. And acute scrotal enlargement, find out what's causing it. it probably warrants hospital care, inpatient treatment, and perhaps consider that a tetanus toxoid booster might also be really helpful for that individual. Seminomas are the most common of the tumors of the stallion's testes. The ones most often reported, though, are seminomas, teratomas, Sertoli cells, and some interstitial cell tumors. Approximately in that order is how frequently they happen. And most of the time, people are unaware that the stallion has an abnormal testes. They're most often identified at the time of a breeding or semen collection when you notice that there's a change in the size of one of the testes. It's like, oh, how did I miss that? And it may be then also by then coupled with reduced fertility, and occasionally you'll have some pain exhibited by a stallion. But that change in testicular size could also be the result of an orchitis or epididymitis. So ultrasound is that first important step, but your follow-up to make sure you know what the etiology is should include probably bacterial cultures and test him for EIA, EVA, maybe even a strongylosis infection or autoimmune disease. So scrotal enlargement can have a number of different etiologies, but start with ultrasound, measure the testes by ultrasound, cranial, caudal, dorsal, ventral, medial, lateral ultrasound measurements, and record those, because over time you may find that testicular size decreases, so he may be undergoing testicular degeneration. And that would give you a means of tracking how devastating the changes are that he's undergoing and whether or not they may be reversible. If you have identified scrotal abnormalities, you'll know what the tail of the epididymis is, and you'll know the structures that will help you identify the caudal ligament of the epididymis that attaches the epididymal tail to the caudal testes. In addition, with these stallions, always examine the internal and external inguinal rings. Determine what abnormal structures may be imposing on those areas and actually causing abnormal testicular position. Check the temperature of the testes. As that spermatic cord torsion I said that testis was already cold by the stallion, by the time the stallion arrived for me. Testicular hypoplasia, on the other hand, is generally a congenital finding, and the testes can be really small. These are cryptorchid testes. The one here was very small. The one over here looks quite abnormal, and it's just as a note to say that I neglect to do this early. Cryptorchid testes have an increased incidence for neoplasia. And the incidence in descended testes is generally first with seminoma, but if it's actually retained in the abdomen, teratoma will much more likely be the one that you will identify. And then sometimes you'll see as testes degenerate, you'll see some mineralization of that tissue. And the last, I'm going to show this slide and then back up to the other one because I have another video clip that Dr. Tabari sent me that I think is really important to make a clinical point. This little guy, though, was a 3-year-old standardbred stallion that was brought to Michigan from California. 3-year-old, they thought he was going to be the cat's meow. He's going to be the best horse out there for the breeding they wanted. And nobody ever laid a hand on his scrotum. You can see how small were his testes. They're actually about the same size as the tail of the epididymis, and completely useless horse when it came to breeding. He was a nice fellow, but he ended up actually being castrated and then going back into racing as a gelding. So that was a miss as far as that farm was concerned, that they purchased this horse based on his pedigree and never bothered to have an exam done. So I want to take you back to this one. This is a case of a scrotal hernia, and you can see that inside the scrotum we had this loop of bowel. And so one of the biggest mistakes you can make when you're in practice, if you really want to do harm, this would be the way to do it. If you have a scrotal enlargement, you've got to know what's causing it. Just because it's tempting, don't put a needle in it and do an aspiration and see what the heck's going on. because in this instance, there was a loop of bowel that had dropped down through the internal inguinal ring that was very large on this horse, and the loop of bowel was located in the scrotum. And had you put a needle in that to aspirate it and find out the nature of the content, what you would probably have caused is GI leakage of that content into the scrotum and between the testes and the tunics, and that would be a disaster. So what I'm going to try to do now, that was my last slide on that. We tried to work with this earlier. I'm going to see if it works, and it's my last little bit. I have it disappeared on me. I'm going to try to come back into the file I have from Dr. Tabari and show you a video clip that he sent me. And it's pretty neat because it's a way to, I guess I'm going to have to minimize that one. Oh, here it is. All right, so let's see if it works. This is a case of, it is that case that shows the testes here within the scrotum. You can see a little bit of the pampiniform plexus, which what you notice within the scrotum is all of this peristalsis of the loop of gut that is down within the scrotum around the testes. And you sure want to know that you will never put a needle into that scrotum and try to determine what it is that's actually causing that problem with the testes. So folks, that is all I had for you. I do believe I've gone way over time, and I apologize for that, but I hope I have at least addressed some of your questions or concerns or curiosities, and I thank you very much for your time and attention.
Dr. Carla?
Yes.
Yeah. So thank you for nearly 2 hours of lecture. We really enjoyed it. And we have received about 403 questions.
Okay. All right.
Yes. So because of want of time, so we have restricted to 4 questions. And many of the questions I think we'll be sending to you with, and you may answer it across the mail. So,
okay.
So one of the question is, what are the features of a broad ligament hematoma through ultrasound? The features of broad ligament hematoma through ultrasound.
Well, as far as what you can do with it, it's mostly a matter of monitoring it. What I look for, if I have a broad ligament hematoma, my goal first off, especially if the mare has a folate side, is to have her survive, so that she can lactate and raise her foal, because there's nothing better for the survival of that youngster than to have his mom around during that period of time. But over time, what I will do to kind of monitor her pursuit of life is to say, with serial palpations, once I get past that first most dangerous 2 weeks, is just watch it with palpation, but more likely with ultrasound, because it takes very little pressure, and to watch and confirm that the clots are contracting, that there isn't continuing bleeding, and that we can give her a prognosis for survival, but not for future breeding.
Okay. Thank you. But can you stop sharing the PowerPoint?
Yes. Okay, so let me see.
We are not able to see you at all. We continue to.
Oh no! Well, oh no, that's probably better. You have to realize I had to get up at 6 o'clock to do this, and I did brush my hair, but beyond that, you have to be tolerant.
No problem. Okay. So, what is the difference between hemorrhagic anovulatory follicle and hematoma?
The hematoma is post-ovulation, and the anovulatory follicle has hemorrhaged within the follicular space, but the ovum has not escaped. It has become trapped within that follicular space, and so it degenerates, and there's no chance for a conception or a pregnancy. Whereas a hematoma, if she was bred at that time, even though she develops this large fluid-filled structure, will still has the potential to conceiving and having a pregnancy. And it's actually quite nice if that mare is going to have a hematoma and do it anyway, that she ovulates and conceives on that, because then I don't have to worry how long it's going to take for her to have that structure luteinized so I can start over.
Thank you. So at what stage we can detect fetal deformities during pregnancy through ultrasound?
Well, okay. I have found some where I had brachial arch developmental abnormalities, and I saw some of that with this enormous neck and the abnormalities of that early embryological development during the period of organogenesis. So I would say sometimes the abnormalities may be the fact that the heart itself hasn't developed well. That can be 25 or 30 days along, but it's more likely that you're going to be noting these things between probably 45 and 100 days.
Okay, thank you very much. May I request our Director of Clinics, Dr. Paul Subramanian, for his concluding remarks. Thank you once again, Dr. Carla, for a 2 hours lecture. We really enjoyed.
Thank you very much. I apologize for going over so long.
No. So we really enjoyed it. Okay.
Hello, Dr. Carla Carleton.
Yes.
Dr. Balasubramanian, Director of Clinics. I just wanted to just say a few points. First one, nothing related to your topic, your presentation, because it goes without saying that being an eminent personality in this particular field, I know you since 1994. But I don't know. I'll just rewind and take you back to 1994 when you were in India. I met you in the residence of Dr. Karthikeyan. I don't know whether you remember me.
I actually do, and I remember Kati very well. I consider him to be a very fine friend and lovely fellow, as well as his wife and his daughter Paplu.
Yes. So, in fact, I met you in 1994. At that point of time, maybe in April, if my memory is correct. So you were here, and I approached you for a postdoctoral position, and you asked me to meet, and I brought my CV, and maybe around 6:30 or 7 in the evening, late evening. So at that time, you said one of your postdoc. Probably she would be on maternity leave, long leave. So I think I have an opening. So if you're interested, then maybe in June or July you can try to come. But it was so unfortunate. In July, I think I told you I was about to get married in July, and I got married in July. So I could not accept your offer at that time. So this is the first point which I need to just recollect and then tell you. And the second one, my classmate, Dr. Ramanathan, is your very close friend.
He is. Yes, he is.
Yes, that is the second point. So the overall lecture was very informative, very illustrative, because normally there'll be a lot of text material. This shows your experience. So we could see only the pictures and a few words in the slides, except for the last few slides where it is on Stallion. I could find 2-3 lines, that's all. But otherwise, all were illustrative. So I think definitely people who had registered and participated in this webinar would have definitely got benefited because of your rich experience, the way of presentation. Thank you very much, and hope we'll meet sometime again when you are in India, probably after this pandemic is over. Thank you, Dr. Carla.
Thank you very much. I appreciate that. And you realize that I've been going to India now the first time when my parents lived in Delhi.
Yes, I know that.
And so they lived there for 6 years. And so I think I've been to India anywhere from 1 to 4 times a year since 1992. Yes. So it has become my second home. So I appreciate the opportunity today. Thank you.
Thank you very much. Have a nice day.
You too. Thank you. Bye-bye.
Yeah, thank you, Dr. Carla. So maybe because of COVID, we are not able to call. When the situation becomes all right, if we get an opportunity, we'll go for something like workshop or something like by calling you. Oh, thank you once again, and I call upon Dr. Gauri Professor for a vote of thanks.
Good evening, everybody, and good morning, ma'am. It is
Good
my
morning.
privilege to propose vote of thanks on behalf of the organizing committee, TANUVAS Global Veterinary Large Animal Sciences Webinar Series 2020. First of all, I would like to thank our Honorable Vice Chancellor, TANUVAS, for readily accepting the invitation and delivering the presidential address. Thank you, sir. I would like to extend our sincere thanks to Director of Clinics, Convener and Chairman of the webinar for the support and valuable guidance in conducting the webinar successfully. And thank you, sir. With immense pleasure, I would like to thank today's speaker, Professor Emeritus Dr. Carla Carleton, for updating the skills on equine reproductive ultrasonography and for their valuable information. Thank you, ma'am.
Thank you very much.
Yeah. I would like to thank Vice President Alembic, Mr. Karnanidhi, and Dr. Santosh Shinde Alembic for the technical support. Thank you, sir. And I would like to thank our Dean, Madras Veterinary College, for providing the conference hall and also the technical support to conduct the program. I also thank Dean VCRI Namakkal, Dean VCRI Tirunelveli, and Dean VCRI Orthonaut for their valuable support in conducting the program. Thank you, sir. And last but least, I also thank my colleagues and also the other people who have helped in conducting the program and my subordinates for the support in conducting the webinar successfully. Thank you, sir. I thank Professor and Head, Department of Animal Husbandry Extension, and Dr. Vimal Raj, Assistant Professor, Department of Animal Husbandry Extension, and Dr. P. Tirunavakar, sir, Animal Husbandry Statistics, for providing the technical support. Thank you, sir. Thank you.
Thank you, participants, and thank you, Dr. Carla. Thank you so much.